Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. Today, in continuity with the previous lectures, that is on examination in CNS, or we call nervous system examination. Today we'll be dealing with sensory system examination, and it is very important while you are examining any patient for nervous system. This will be very frequently asked to you in your oral exams as well as in your theory exams also. Good number of things can be asked in your theory also, and you will come across in everyday practice. Most common disorder you will come across in your everyday practice is peripheral neuropathy due to diabetes and due to alcohol, as well as because of B12 deficiency. You will come across these three common. But today we are going to deal with only how you examine sensory nervous system. So sensory system, you know very well, any stimulus to the periphery receptor, which we call as a sensory receptor, that will convert that stimulus into an electrical impulse and will be transmitted via the first order neuron, second order neuron and third order neuron to cerebral cortex, and your brain will be able to recognize that sensation. And there are different types of sensation: light touch, deep touch, pressure, temperature, hot and cold, vibration sensation, then joint sensation, movements, kinesthetic sensation, etc. All these sensations are finally relayed into cerebral cortex, we call as a post-central gyrus or parietal lobe, which is a part of parietal lobe, and to the opposite side of the body. So we'll be giving a little idea regarding a sensory system, and then we'll be going through. Just in this diagram only I can easily explain that fine touch, then pain sensation and pressure sensation. Three sensations are shown here. You can see that fine touch runs on the same side, ascends on the same side, and at the level of medulla crosses to the opposite side. And then it ends into thalamus, and from thalamus into cerebral cortex. So this is called first order neuron. Then it will end in medulla, and in medulla second order neuron will cross to the opposite side and will end in a opposite side thalamus and opposite side cerebral cortex. While you can see this pain temperature, pain receptor, it already crosses at the level of entry to the opposite side and runs in spinothalamic tract, and there will be another group that is called touch that will also run in the opposite side. That pain fiber will be running in posterior spinothalamic, or we call lateral spinothalamic, and pressure or touch, that will be touch and pressure, will be running in anterior spinothalamic and will be running on the opposite side in the spinothalamic tract. These are already we call as a cross fiber, and then it will run and ends in a posterior ventro-posterolateral nucleus of thalamus, and from there into cerebral cortex. So first order neuron remains on the same side, second order neuron always cross to the opposite side, and then third order neuron will end in, so second order neuron will end in thalamus, and from thalamus via thalamocortical tract, which are sensory fiber which will run via internal capsule in the posterior limb of the internal capsule and will end in post central gyrus of parietal lobe. In short, so we'll be dealing with little introduction, little anatomy. So we have got different receptor, we call mechanoreceptor, which will respond to touch and pressure, thermoreceptor, which will respond to temperature, photoreceptor, that is to the light, that is we are not dealing at present, that is by retina. Chemoreceptor will be present in say olfactory area, and also in a gustatory area. Then nociceptors are pain fibers. Then there are exteroreceptors, which are by response to the stimulus outside the body. Interoreceptors, which are present inside the body and they respond to the internal stimulus. And proprioceptive sensation, they are fibers, and there are receptors which are present in tendon, muscles, etc. So these are the different types of receptor. So we have got a cutaneous receptor, we have got a receptor in the muscle, tendon, etc. And in muscle we have got muscle spindle, Golgi apparatus, while in a cutaneous we have got a Pacinius corpuscle, cross raffinus body, Meissner's body, free nerve ending, and nerve supply to the hair follicles. These are all the different types of receptor. I am not dealing at all with those different receptors. We take it for granted. There are tactile receptor called Pacinius corpuscle, raffinus corpuscle, and free nerve ending. For light touch, Merkel's disc, Meissner's corpuscle, hair follicle, and for pain, free nerve endings. And again in that we have got two types, delta fibers and C fibers. Delta fiber is for sharp pain and cold temperature, cold sensation, while C fiber is for dull pain, cold and warm temperature. So these are the few receptors. We divide into superficial sensation and deep sensation. Superficial is pain, touch and temperature, while deep sensation will be to the tendon, bones, then ligaments, muscles, etc., which will be for joint sensation, vibration sensation and deep pressure. And then they go to they end in a cortex, and in a cortex will be able to localize, discriminate, stereognosis, graphesthesia, then 2-point discrimination, etc. Entire all those are cortical sensations. Will be showing you further. So we divide into skin and musculoskeletal system. Skin will be superficial sensation, pain, touch and temperature, while musculoskeletal system will be proprioceptive sensation and even pain sensation. In proprioceptive, position of sense by pressure and vibration. Kinesthetic sensation at the level of joint. So deep sensation and proprioceptive sensation will be a part of musculoskeletal system, while skin will be superficial sensation. Now all those sensations from those receptors will be carried by different nerves, we call spinal nerves. We have got 8 cervical, 12 thoracic, 5 lumbar, 5 sacral and 1 coccygeal. Totally it makes 31 pairs. 8 cervical, 12 thoracic, 5 lumbar, 5 sacral and 1 coccygeal. So we have got totally 31 pairs of spinal nerves. We are not at present talking about cranial nerves, and in cranial nerves we have got some sensory nerves. So those cranial nerves will carry the sensation from those areas to cerebral cortex. Particularly trigeminal nerve will be carrying the sensation from the face, will be carrying the sensation to the cerebral cortex. So that will be. Now as far as relation of the spinal nerves to the vertebra, so upper cervical spinal segment 2, C2 is at the level of C2, same level, but C6 vertebral level will be C5, 1 vertebra above. T5 will be 2 vertebra above. So it will be T5 segment of spinal cord will be at the level of T3. T10 will be at the level of T7, that is 3 vertebra above. So we always say at C2 same, at C6 1 below. So at C5 level 1 segment will be below, and at T3 level it will be 2 segment. So you add 1 at the lower part of the cervical, 2 at the upper part of thoracic, 3 at the lower part of thoracic, means at T7 it will be T10, at T8 it will be T11, So that will be the way. And lumbar segment will be at the level of T10 to T11. So roughly you add between 3 to 5. So at T11 it will be almost lumbar 5 segment. Lumbar 5 segment. And at the level of sacral and coccygeal, that will be at the level of T12 to L1. So our spinal cord will end at the lower part of L1 vertebra, and then you will have cauda equina. So that will be the roots of lower part of the spinal cord. And this peripheral nervous spinal nerves, when they come closer to the spinal cord, they unite and they form what we call as a plexus. Cervical plexus will be C1 to C5. Brachial plexus will be C5 to T1. Lumbar plexus will be L1 to L4. And sacral plexus will be L4 to S4. So this will be the 4 plexus. Cervical plexus, brachial plexus, lumbar plexus. Hello? हाँ बोलो. પછી બોલજે અત્યારે મારે કામમાં છું કલાક સવા કલાક પછી. હા. So lumbar plexus, sacral plexus. So this will be the 4 plexus, and then it will enter into spinal cord. So those sensory fiber via posterior root will be entering into spinal cord. So they will enter via the posterior root ganglia. So at the posterior root ganglia, it is a bipolar fiber. So one fiber will enter into the spinal cord and one fiber is attached to peripheral receptors. Now the fiber which enters into the spinal cord, now depending upon the type of sensation what it is carrying, the dorsal column fiber will run on the same side. That will be running into what we call as a dorsal columns, that is tractus gracilis and fascicles, cuneatus, gracilis and cuneatus. So that will be running on the same side, and then they will end into medulla, where they will end into nucleus cuneatus and nucleus gracilis, and they will be carrying fine touch, vibration and proprioceptive sensation from the same side of the body up to medulla, and then the fiber will cross to the opposite side. Those fiber will run up and will end in thalamus, while lateral spinothalamic fibers which will be carrying pain and temperature. So there will be fiber for pain and temperature which will be running in the lateral column, which we call as a posterior or lateral spinothalamic tract. And that lateral spinothalamic tract, even if you see here, the cervical fiber will be medial most, then thoracic fiber, then lumbar, and then sacral. While here if you see, sacral is the medial most and cervical will be lateral most. So that will be in a posterior arrangement in a posterior column, while in the lateral column cervical fibers are medial most, and same thing is there for anterior spinothalamic, that is touch and pressure. So cervical is medial most and sacral is lateral most, and they will be ascending on the opposite side. So they are second order neuron, and those particular fiber will end in VPL nucleus, ventero-posterior-lateral nucleus of thalamus, and from thalamus, thalamocortical fiber, third order neuron, will end on the opposite side cerebral cortex. So this will be the arrangement. This is a posterior column, tractus, cuneatus and gracilis. Gracilis is medial, cuneatus is lateral. So cervical fiber are medial most in spinothalamic tracts, while sacral fibers are outermost. So that is lateral, and these are medial. While here you can see sacral are medial and cervical is lateral. So do remember this. So this will be the 3 common tracts, while spinothalamic tract which are crossing to the opposite side in front of the spinal canal. So they are very closely related to the central canal of spinal cord. And first order neuron will end in a posterior horn, and then from that the second order neuron will cross to the opposite side. While the fiber of the spinothalamic tract, which has crossed to the opposite side, while the fiber of spinocerebellar tracts, they run, some group of fiber will run on the same side, some are already cross fibers, but they will run on the same side. They will be carrying unconscious sensation, while posterior column and spinothalamic will be carrying conscious sensation. So spinocerebellar tracts will be carrying sensation to cerebellum, and then cerebellum via all different connections. They are connected. Cerebellum is connected to lot of structures in the brainstem, and finally those sensations will be given to cerebral cortex, and then that will be related to cerebral cortex. Will be showing you that. So ascending pathway, we have got fine touch, proprioceptive, vibration, pain, temperature, crude touch, and proprioceptive sensation. So dorsal column will be carrying, that is gracilis and cuneatus. So gracilis will be medial most, cuneatus will be lateral. You can see this gracilis is medial most, cuneatus is lateral. So that will be the way. So this will be close to the center, it is sacral. The close to the posterior horn, this is posterior horn. So close to the posterior horn will be cervical. Spinothalamic will be divided into two, anterior and posterior. Anterior will be carrying fine touch, posterior will be carrying pain and temperature. While spinocerebellar will be posterior, or we call dorsal, and anterior, and they will be carrying unconscious sensation. Here you can see that receptor will give an input, will be carried by peripheral nerve on the ipsilateral side. Then it will go to the ipsilateral posterior root ganglia. Then from that to the posterior horn in the form of ascending tracts. Now some of the fiber will run on the same side, and after ending either in the spinal cord or in the brainstem, then second order neuron. So in a spinal cord you will get the end of spinothalamic. So second order neuron will already cross in the spinal cord, while posterior column they will end in medulla, and they will cross over to the opposite side, and they will run in. So it will run to the opposite side in medial laminiscus. So medial laminiscus will be containing the fiber of spinothalamic tract as well as dorsal column, or we call posterior column. So posterior spinothalamic and anterior spinothalamic, both plus posterior column fiber, all will be running in a medial laminiscus, and then they will end in a thalamus. And from thalamus you will have a thalamo-cortical tracts, and they will run via internal capsule and finally end in the cerebral cortex, which will be post-central gyrus, a part of a parietal lobe. So these are the different functions. Lateral spinothalamic, or we call posterior spinothalamic, pain and temperature. Anterior spinothalamic, touch and pressure. Posterior column, conscious proprioceptive sensation, touch and vibration. While spinocerebellar tracts will be mainly unconscious sensation, which will be again proprioceptive, joint, skin, subcutaneous tissue, etc. to the same side cerebellum. So this will be in general showing you the sensory impulses, how from the skin will be carried to the spinal cord, then via two types of tracts. One tract which will cross to the opposite side, that is spinothalamic tract, and dorsal column will be on the same side. Dorsal column will end, second order neuron will start from nucleus cuneatus and gracilis, which will cross to the opposite side. Then both together will be running in a medial laminiscus, and then they will end in thalamus, and from thalamus, thalamocortical tract will end into sensory part of the cerebral cortex. We call it a post-central gyrus, or we call part of parietal lobe. As far as trigeminal nerve is concerned, the trigeminal nerve fiber will cross at the level of medulla, will cross at the level of pons and medulla. Some of the fiber will be descending down and then they will be crossing. So some fiber will be already descending down and then they will cross. So, but they will cross to the opposite side and they will run along with the medial laminiscus. And then it will be ending in the posterior side or ventro-posterolateral nucleus of thalamus and then to the cerebral cortex. So already spinothalamic tracts are already crossed at the level of spinal cord, while nucleus cuneatus and gracilis, from there the second order neuron will cross to the opposite side. They will run along with medial laminiscus, and then it will be combined with the sensory fiber of fifth cranial nerve, and they will run to thalamus, and then they will end in a cerebral cortex. So this is conscious proprioceptive sensation, which will be running in a posterior column. So they will ascend up in a spinal cord in a posterior column. They will end in pons, and then the fiber will end in nucleus cuneatus and gracilis, and they will cross to the opposite side. Second order neuron will then ascend up, end in thalamus, and then it will end into cerebral cortex, and it will give rise to conscious position, touch, vibration, and joint sensation. So that will be conscious proprioceptive fine touch and vibration sensation will be delivered by posterior column. See, they are ascending up. So tractus gracilis and cuneatus. Then they will end in second order neuron will cross over to the opposite side, and they will run in a medial laminiscus, ends in thalamus, VPL nucleus of thalamus, then thalamic, what we call is the thalamocortical fibers. So this is dorsal column, or we call posterior column, and that is sensory neuron, dorsal column, thalamus, primary sensory cortex. So always remember, some person remember, whichever way you want to remember, forget about that. Then pain and temperature sensation will be carried by lateral spinothalamic, and fine touch and pressure will be carried by anterior spinothalamic. But this second order neuron means this first order neuron, you can see that first order neuron is ending in a posterior horn. It ends there. And then second order neuron will cross to the opposite side in lateral spinothalamic and anterior spinothalamic. And both will ascend up to thalamus. They will end in thalamus. That will be third order neuron will start from now thalamus, and they'll go to cerebral cortex. So these are spinothalamic tract. That is pain and temperature. Now this is from trigeminal. You can see that it will end in a trigeminal sensory nucleus. Then after ending that, the second order neuron will start. Some fiber will descend down. Some fiber will cross at the same level. And all those will ascend up in trigeminal laminiscus and will end in thalamus, and from thalamus it will end into post-central gyrus. This will be trigeminal sensation from the face and partly from glossopharyngeal nucleus, sensory nucleus of glossopharyngeal. While unconscious sensation, that is by spinocerebellar tract, posterior spinocerebellum and anterior spinocerebellar tracts, they will end in cerebellum. Now we have got all different type of sensations. Now there are some symptoms which are due to stimulation, like pain. We can get increased pain sensation, we call hyperalgesia, or there is one word you utilize is hyperpathia, or there is one where superficial sensation, touch sensation is converted into pain sensation, we call dysesthesia or hyperesthesia. And person without any stimulus continuously complains of pins and needles or burning sensation, that we call as a paresthesia. So paresthesia is without any stimulus, we call tingling numbness or pins and needles or burning sensation, that is paresthesia, which is a very early sign of peripheral neuropathy. While hyperesthesia is because of stimulation, touch sensation is interpreted as a pain sensation, and that is also referred as dysesthesia or allodynia. So touch is interpreted as pain. Neuralgia will be the pain because of compression of the nerve fiber, and that will give rise to root pain, or we call root pain or neuralgic pain. And there is a hyperalgesia. When threshold to the pain is lowered, we call hyperalgesia. And when threshold is elevated, it is called hyperpathia. So you require more painful stimulus. Pain threshold is elevated, but once it reaches, then painful stimulus is excessively felt. So that is hyperpathia. So these are some of the words which are being utilized. Causalgia is a spontaneous burning sensation in the distribution of nerve, injured nerve, with increased sensitivity. That is, and phantom limb is because of the nerve terminal ending in an amputated limb. If that is stimulated, person feels as if the sensation is there in the part which has been amputated. That is called phantom limb. These are called positive symptoms. While negative symptoms means because of damage now to the sensory fibers or sensory neurons, or because of we'll say receptors or peripheral nerves, then that will give rise to diminished response to the stimulus. We call hypoalgesia, means decreased sensitivity to pain. Hypoesthesia means decreased sensitivity to any stimulus. And analgesia or anesthesia, total anesthesia. Analgesia means decreased sensitivity to or absent sensitivity to painful stimulus, and anesthesia means to any stimulus. And there is something called as dissociative, means some sensation are preserved, some sensation are lost. Classically, it will happen if there is a damage at the level of spinal canal. Classical disorder which will produce that is syringomyelia, will damage the spinothalamic tracts, both spinothalamic tract, and person will have a loss of pain and temperature sensation on both the side because they cross just in front of the spinal canal, and person will have preservation of posterior column sensation, and that is called dissociative anesthesia. So you can have hypoesthesia or total anesthesia, or person can have hyperesthesia, dysesthesia or allodynia, or dissociative anesthesia. And secondary to this hypoesthesia or anesthesia, person will start getting changes we call trophic changes, and whenever there is a damage to the cerebral cortex, person can have difficulty localization, discrimination, 2-point discrimination, absence of stereognosis we call it as astereognosis, and absence of graphesthesia we call as agraphesthesia. These are all we call cortical sensation. So this will be the different findings. So whenever you do an examination, you should do the examination for fine touch, crude touch, tactile localization, 2-point discrimination, stereognosis, baryognosis, and graphesthesia. This localization, discrimination, stereognosis, baryognosis, and graphesthesia are cortical sensation, while fine touch, crude touch are peripheral sensation. You can also look for what we call as kinesthetic sensation, like sense of position, joint movement, vibration, etc. are for posterior column, while superficial pain, pressure pain is mainly for spinothalamic tract. Temperature is also for lateral spinothalamic tract. Crude touch is for anterior spinothalamic. So these are the different columns which will be related for those sensations. So while doing an examination, there are certain procedures which we follow. You always first introduce yourself, have a cleaning, you clean your hands properly, you introduce, take the permission, and then you start examination. And while examining, the part which you are examining should be completely exposed. For touch, you use cotton. For pain, you use a sharp point which should be sterile. Then for vibration, you use a tuning fork. For temperature, you use a test tube containing a hot water and cold water, or there are instrument which is having a hot temperature and cold temperature, etc. And you, whenever you do a identification, or we call as a person is able to recognize or not, you explain the person, whenever I touch you, you are supposed to answer yes or no. So person will be answering, he can feel or no. And whenever you ask where, and if he is able to localize, that is a cortical sensation, we call localization, discrimination, 2-point discrimination, etc. So while doing this test, first you try to identify whether the person can identify or not. If person is able to identify, then we go for localization, discrimination, 2-point discrimination, then stereognosis, graphesthesia, etc. So those are the way in which you do it. And while examining, you will be identifying whether the person is having hypoaesthesia, anesthesia, hypoalgesia, analgesia, dissociative anesthesia, whether he is having a trophic changes, all those things you will have to examine. So explain the person. Person is supposed to close the eye during testing, and he is supposed to answer only yes or no. And we ask a question, do you feel? He is supposed to answer yes or no. And if yes, then only we ask where and how many. And this is for identification. And then when you ask where and how many, where is for localization, how many is for discrimination and 2-point discrimination. First, we always examine in a major areas. So we call dermatomes areas. And then if a person has got a sensory loss, then we check in a small area to find out the area of sensory loss. So with the eye closed, person is supposed to interpret the sensation, and then he is supposed to localize and discriminate. And then you can reduce the area of sensory area. Also, you should look for, because whenever sensory system is affected, it will also affect the reflexes. And you can look for skin changes. And you ask the question whether you can identify or not, and whether you can localize or not, where. So touch sensation is done by cotton, pain sensation by pin. This is pin. This is pressure sensation by blunt object. Vibration is by tuning fork. Temperature is by the test tube containing a hot water and cold water. Kinesthetic sensation by the movement at the joint. Stereognosis by giving a familiar object in the palm. Graphesthesia by drawing the familiar shapes, alphabets, figures, etc. in the palm or over the body. And you can test in a lower limb, upper limb, and over the face, abdomen, chest, etc. depending upon where are the symptoms. So light touch is for dorsal column, proprioceptive is for dorsal column, vibration is for dorsal column, pain and temperature is for spinothalamic tract, that is lateral spinothalamic tract, while crude touch is by anterior spinothalamic. So these are the columns which you are testing. So touch sensation, vibration sensation, proprioceptive sensation, stereognosis, graphesthesia, 2-point discrimination. So stereognosis, graphesthesia, 2-point discrimination, localization, all those are for cortical sensation. So this is stereognosis, this is graphesthesia, this is Rhombug test, This is 2-point discrimination, and this is for first identifying whether he can feel or not, means recognition. And then if you ask where, then it is localization. We'll be doing all those things. So touch is done by cotton. You can do in a different area and you ask the person whether he can recognize or not. And once he recognized, then you can ask where and how many. When you ask where, it is localization. When you ask how many and where, that is 2-point discrimination. Discrimination is on the two opposite side, and 2-point discrimination in the same area with a distance. So for touch, this will be the common things which is being cotton wick is commonly being utilized, and you can utilize monofilaments. Mainly monofilament is very frequently utilized in a peripheral neuropathy identification. So those are called monofilaments for touch sensation. For pain sensation, sharp point, but it should be sterile and with a single point. So these are the different things which are being utilized. Sharp point is being utilized. You can use a surgical needle point. These are the different pain sensation. While temperature is by test tubes containing different temperatures, cold temperature or hot temperatures. Or you can have an instrument which is having a hot part and cold part. Proprioceptive sensation is done by movement at the joints. If I get a video of examining a proprioceptive sensation, I'll upload that. So that is by joint movement, and there is a typical method of testing. Typical method, you will have to hold the joint with two and move the joints so that person doesn't identify the joint movement by pressure. For vibration sensation, you utilize the frequency 128 tuning fork, and after vibrating the tuning fork, you put it at the joint on the bony points. So after that you will be able to identify there is hypoesthesia, hyperesthesia, or there is anesthesia, etc. You will be able to identify. Paresthesia is mainly the symptom. You will be able to identify hypo, hyper, anesthesia, etc. And you will have to make out in which area it is. So now I'm showing you video if it is possible. Yes, you can see that video. So first wash your hand, introduce, take a permission, expose the part, and then you will do the sensation. You put the person in a proper position. After explaining what you are going to do, here she is explaining what she is going to do, and she is taking a permission. And after taking a permission, you ask the person to lie down. Best way is by lying down posture, and the part to be examined has to be exposed.
For this examination, you will need cotton
This is
wool,
touch sensation done by cotton, while pain sensation is done by this prick needle, and this is vibration sensation, which is 128
The first section of the examination requires knowledge of the dermatomes
frequency.
of the limb. The dermatomes
And
we're
you
testing
should be
are
little aware of
C4,
which are the
C5,
dermatomes.
C6,
Say this is
C7,
C5, this is C6,
C8,
this is
and
C7,
T11.
this is C8.
We will be testing
So you
three
should be
different
aware of that.
modalities in a dermatome
And what you are
distribution.
testing:
These are
light touch, pain, temperature,
and
vibration, and
It
proprioceptive
is important
sensation.
to test each dermatome in turn, comparing the sensation of the right with the left. In addition, pay close attention to the points at which each dermatome is tested. Firstly, we will be testing light touch.
This is
We will be
light
using
touch.
the cotton wool for this. Note firstly, you must demonstrate the sensation centrally on the patient's chest. Then, ask them to close their eyes while you test each dermatome in turn.
Can I ask you to lay your arms out
Like this.
After explaining, see, she has drawn the line. We don't have to draw those lines, but you should be aware that this is C5, this is C6, this is 7, 8, this is 8, this is T1. First, you touch on the normal area on the face. You explain that I am going to touch. You are supposed to answer yes or no. And then after closing the eye, she is supposed to answer yes or no. This is C4, this is C5, this is C5, this is C6. Then C7. C7 is middle finger. C8 is little finger. Then inner side is, that is T1. And much higher, T2. So same way you can do for pain, you can do for vibration. This is for pain sensation.
Can you feel that? Does it feel sharp? Can I ask you to close your eyes and let me know if you can feel me touching you with this, and whether it feels sharp and feels the same on both sides. Okay. Can you close your eyes for me, please? Does that feel sharp? Yes, it does. Does it feel the same on both sides? With this modality, it is important to explain to the patient.
And you are testing with a closed eye. And person is supposed to say yes or no only. But when you ask where, then you are going to deal with localization. And how many will be discrimination. This is temperature. No, this is vibration sensation. After striking a tuning fork, you are putting on a bony prominence. That is on the sternum.
Can I ask you to close your eyes in a moment and let me know if you feel me touching the tuning fork, if it feels cold, and if it feels the same on both sides. Okay. Can you close your eyes for me? Yes, cold.
This is, she is putting on an acromion process.
Same on both sides?
That was for vibration sensation.
Patient's vibration sense. This is carried out by again using the 128 Hz tuning fork. As with the other domains, ensure you assess the patient's sensation centrally first. If the patient cannot feel the vibration at the metacarpal
Vibration sensation is posterior column.
move proximally to the
Temperature
styloid
and
process
pain
and
is
the olecranon
lateral
process.
spinothalamic.
I'm now
Fine
going to
touch
test your vibration
is by
sensation using this
crude
tuning
touch
fork.
is
First
by
of all, I'll place
anterior
it.
spinothalamic.
I'd like you to let me know if you feel it vibrating and when you feel it stop. Okay? Can you feel that vibrating? Yeah. Let me know.
This video is also showing you how you are examining. This I have collected from YouTube.
Hello, Emma.
This
My
is a very
name's
nice
Amy.
video.
Would it be okay if I examined you?
Yes.
First, she
Begin
is
with
introducing,
light touch,
she is
using the
explaining,
wrist of
and then
cotton
she is
wool.
doing the test
Lightly
for
apply your finger.
touch, pain,
Please look at the ceiling.
and vibration
I'm
sensation.
going to touch your legs with some cotton wool. Please say yes when you feel me touch you.
So, person is supposed to answer yes or no.
Time the stimuli irregularly, making a dabbing
Here,
rather than a stroking or
he has
tickling
kept eye open, but ideally,
Compare side by
for
side
while you are
for
testing
symmetry.
in a lower limb, you may not require eye to be closed, but ideally, eye should be closed. This you are testing in a different areas.
Yes.
And then if you find some negative findings, you should test in a small areas. This is in a big area. We call dermatomes.
Did it feel the same on both sides?
Yes. Use a neurological pin to test pain.
I'm now going to touch your legs with a small pin.
This is for pain
Do you feel
sensation,
it here?
and then it
Yes,
will be
sharp.
for vibration sensation. I'll be go to another. And then when you go for, if any person who has got a severe loss of sensation in a lower limb, sensory loss in lower limb, then Rhombug test will be positive. We call sensory ataxia. So for Rhombug test, person is supposed to stand on the feet together, first initially with eye open, and when the person is standing with 2 feet together, eye open, you see that the two arms are by the side, and always stand on the back, so that when person, if he is having ataxia, he should not get fall and injury. And then person is supposed to close the eye, and after closing the eye, if person sways, Rhombug test is positive. Now while maintaining that, if a person is moving the arm away and he is using a broad base, that means person is having Rhombug test positive. So person is supposed to keep the two legs together, arm by the side, first starting eye open and then with eye closed, he should be able to maintain the balance. This will be positive in sensory, vestibular and cerebellar disorders. That we call as Rhombug test for finding out posture and equilibrium. So always stand on the back, two legs together, eye closed, arm by the side, and look for the imbalance. In sensory, with eye open, person will be able to maintain the balance either by adjusting little broad base, little arm apart, and as soon as he closes the eye, he will have ataxia or he will have fall or sway. We call Rhombug test positive. While in cerebellar, with eye open or eye closed, the person will have ataxia with eye open or with eye closed. And you can make it more sensitive by modifying. So you ask the person to stand with little head in extension, and then you just touch the arm, which are outstretched arm, and then just give a little tap to the person. So you will be able to differentiate vestibular ataxia from sensory ataxia. And when a person is walking, this is called tandem walking. And if a person gets imbalance, that will be a part of ataxia. This is a walking on a toe. This is a walking on a hill. This is tandem walking. This is walking with a broad base. And this is hooping. So on the toes, on the heel, this is hooping. And this is with a broad base. So sensory ataxia and motor ataxia. I am not going into detail. I am having, say, okay, we'll go through. Sensory ataxia will be because of loss of sensation. Rhombug test will be positive. While in a cerebellar lesion, no Rhombug test. In coordination, when the eye closed, in coordination even with eye open. Here in sensory, no tremors, no involuntary movement. While in motor ataxia, or we call cerebellar, there will be always tremors. And they will be what we call as intentional tremors. Speech will not be affected in sensory, while speech will be staccato speech. The person will have a high steppage gait, or we call stamping gait, while here person will have a cerebellar gait, or we call as totally drunken gait. Nystagmus is never present in sensory ataxia, while nystagmus will be a very common finding in cerebellar ataxia. And also you will have in coordination, finger nose test, finger to finger test, knee heel test, all will be positive in cerebellar lesions. This is the difference between cerebellar, vestibular and sensory. Forget about it. You can go through at leisure time. Otherwise this will be very, very long. Examination of sensory function, cortical sensation, we have told you that when you ask a question, where, and if a person is able to show you with eye closed, we call tactile localization. How many, if he identifies the two spots on two different sides, right and left, or upper limb and lower limb, we call that as a discrimination. While if you touch in the same area, very close by, and if he is able to identify two different stimulus simultaneously, that is called 2-point discrimination. And when you put some object in the palm and person is able to identify familiar object, that is called stereognosis. And if you draw some diagrams, alphabets, or some figures, or say you write down some triangle or so, and if a person is able to identify, that is called Graphesthesia. there is one particular disorder called Justman syndrome. And in that Justman syndrome, person will have acalculia, person will have a right to left confusion, person will have a finger agnosia, and along with that, person will have agraphia. When all these are present, these are not ideally a cortical sensation, but this is a damage to the cortex. That is, acalculia means person is not able to calculate, person is not able to recognize the graphical objects, and person is not able to recognize even the finger. We call finger agnosia, and person cannot identify right and left. That is called Justman syndrome, and that will happen if a person has got damage in the dominant parietal lobe. So we call dominant parietal lobe will produce Justman syndrome along with cortical sensation damage also. And that cortical sensation damage can occur in any lobes, not only in parietal lobe. Means it will be in a parietal lobe, dominant hemisphere will produce Justman, but non-dominant can also produce cortical sensory loss. That will be typical. This is two stimulus simultaneously, one on the face, one on the upper arm, and one is on the right side, one is on the left side. If he is able to identify, this is called discrimination. Here also this is discrimination. This is localization. If you ask the person after closing the eye, where, ask the patient where, then if he is able to identify, we call localization. How many? If he says this two, then it is discrimination. So you can do localization and discrimination. Discrimination you can do for touch, pain, temperature, vibration, pressure, etc. You can do for that. We'll show you that diagram. So localization, discrimination. This is 2-point discrimination. You can see that you are giving two stimulus. This is for pain. This is for touch. And there are special instruments which are available with a little different distance. So this is for 2-point discrimination. These are all the instruments for 2-point discrimination. These are two separate needles and you are doing 2-point discrimination for pain. This is 2-point discrimination for touch. So when you do that, and if a person is able to identify two stimulus, that is called 2-point discrimination is normal. And if he identifies as a single with adequate distance between the two stimulus, then you call as 2-point discrimination is affected. So that can be done for pain, touch, temperature, etc. Commonly those are being done. And person should be able to identify, localize, discriminate, and 2-point discrimination should be proper. So these are the different things which are being utilized. This is for localization, this is for 2-point discrimination. So depending upon the distance, you can say that person has got 2-point discrimination affected or not. This is stereognosis. You are giving a familiar object in the palm and person is supposed to identify. This is stereognosis. While when you do some graphical objects on the palm or on the forearm, and if a person is supposed to identify those by a blunt object, that is called graphesthesia, and if a person cannot identify, a graphesthesia. This is, see, you have written figure 8. If he identifies that, it is called graphesthesia normal. So you write down familiar words, alphabets, etc. or figures. This is stereognosis. If it is absent, astereognosis. And if we cannot identify the number, letters, etc., then we call graphesthesia. These are all cortical functions. And when a person is not able to differentiate between the weight, that is called barognosis or baresthesia. And if we cannot identify, that is one type of sensory loss, means identification of weight. Here you can see tactile localization. Person is explaining what he is going to do the test and he is utilizing an instrument. This is one instrument which he is going to utilize.
About tactile localization
He has explained, he has taken the permission, he has introduced, he has taken the permission, he is utilizing this instrument, he is explaining what he is going to do. Sorry, C. What is C going to do? And then she will be doing the test.
And we're going to, in this case, be touching different parts of her hand and arm, and you can follow the dermatome patterns that we've talked about before.
So this will be the testing for localization. First, initially with one single point, that will be localization. And then when 2 points are utilized, that is for discrimination. This is a sharp point, so this is for pain. When you use a little blunt object, it is for touch. If it is a very sharp point, it is for pain. Sorry, the voice quality in this video is not loud enough. So simultaneously I will be explaining you. So you can see that she is touching with 1 point. This is localization. Localization. And when you touch simultaneously at 2 different parts of the body, that is discrimination. Now here you will see 2-point discrimination.
Yes, I'm going to take the this caliper and I'm going to touch.
See here, this is touch. This is little blunts. When you touch with single, it is localization. And when you touch with the 2 point, see this is single. Now this is 2 point. 2-point discrimination.
Good. I'm going to do it up on the palm.
See here the distance between the 2 is increased because person cannot identify in a small distance. So this is 2-point discrimination. In fingertips, it is the smallest distance. And in the palm, it will be little more. The requirement for the 2-point discrimination is little wider. It is most sensitive in the tip of the finger. Here you can see that the area required or the distance required is little more.
Very good.
Grammarly.
Now this is for 2-point discrimination and Graphesthesia and Stereognosis. See, this is 2-point discrimination. With eye closed, person is supposed to answer how many. You can increase and decrease the distance between the 2 stimulus area.
Is the ability to tell what the object
It will be shortest. This is Graphesthesia. He is giving a familiar objects.
From the feel of its texture and
And
shape,
person is supposed to
and from
recognize.
having previously come across the same object. Ask the patient to shut their eyes and give them a familiar object to handle.
He is supposed to identify the familiar object. And you can repeat the test in opposite palm.
That's good. Now, can I have your other hand, please?
Now he is repeating in opposite palm. Person is able to recognize by touch, temperature, pressure, etc. Person is able to recognize that.
You can open your eyes now. Graphesthesia is the ability to recognize a number.
Now this is
or letter
Graphesthesia.
Being inscribed in the palm of the hand.
Person is writing down the alphabets.
Like the end of an orange stick. Again,
And person is supposed to identify.
When the figure
Or you
is
can
drawn
draw the
on the palm of
triangle,
hand.
square, etc. You can write down the figure or you can write down the alphabets, etc. This is stereognosis. You can repeat the same test in opposite palm. You can do this thing also in a palm.
2-point discrimination, stereognosis.
Now this
and
is the track.
Graphesthesia
The tract responsible is posterior column for touch, etc. But recognition is done by cerebral cortex. So those are cortical functions. Graphesthesia, stereognosis, localization, two-point discrimination, etc. are the function of cerebral cortex. When you do an examination of sensory system, you will be able to find out whether there is anesthesia, whether it is dissociative, whether it is partial or complete loss. Complete loss is anesthesia, partial loss hypoesthesia. If there is some sensation preserved, some sensation are affected, we call dissociative. Classical example I already mentioned, that you will get in a case of a syringomyelia, you will have pain and temperature lost while preservation of touch sensation. Hemianesthesia will be half of the body affected. If you get exaggeration of the sensory stimulus, we call hyperesthesia. If the person, when the touch sensation is perverted into pain sensation, we call as hyperalgesia. So if you have got total loss of pain sensation, analgesia, diminished pain sensation, hypo, and exaggerated pain sensation, hyperalgesia. These are some of the words. And if you look at this particular, if you have got half loss, this will be because of thalamic lesion. If you have got face loss on one side and opposite side sensory loss, this will be in a lateral medullary syndrome. If you have got a complete transverse level, it will be more common in a spinal cord damage. If you have got some sensation preserved on one side and some sensation affected on opposite side, it will be very common in a hemisection. We call it a Brown-Sequard syndrome. If you have got a loss, what we call as in the central part of the chest, it will be more common in a central cord lesion. This will be more common with particularly in a syringomyelia. If you get a sacral sparing, it will be very common with spinal cord damage, particularly we call cauda equina and conus medullare lesion. Saddle anesthesia will be another variety, and if you get glove and stocking type of lesion, it will be peculiar in patient with peripheral neuropathy. So do remember this. So these are some of the lesions you will come across in sensory examination. Always you should be aware of dermatomes and tracks. So depending upon your sensory finding, you can put them into dermatomes, and depending upon dermatomes, you will come closer to the spinal cord region, and depending upon the sensory loss, you can put them into which part of the spinal cord, and that will help in localization. So dermatome localization is very important. You should be aware of that. So I end my lecture here. So I feel this lecture will be helpful to you when you do a sensory examination. If you like this particular lecture, please don't forget to press button like, subscribe and share with your friends. This will be definitely helpful to you in your theory exam, oral exams, and also during your private practice. So I thank you all for taking out time. I know that your time is valuable, and I appreciate that you have spent some of the time with me for listening this lecture. See you in next lecture.